Thank you. So today's presentation is an overview of MDMA. I do believe that when we solicited for topics, this was one of the topic suggestions that was brought forward. So the objectives for this first few minutes of our echo are to describe the mechanism of action. So what exactly does MDMA do? MDMA specifically is 3,4-methylene dioxide methamphetamine, also more commonly known as ecstasy. We're going to identify potential indications. So where is it being used? Then we're going to discuss the literature. So is there support for its use? Just because it's being used somewhere, is there a reason why we should be doing so? And then, because most of our pharmacologic agents come with adverse effects, we're going to list out some of the potential adverse effects. So starting just with our MDMA, it goes by a number of names. It's when I do presentations like this that I'm glad that I'm friends with our IT department, because as they look at my search history, they're like, what exactly are you doing? So there are quite a few different names that MDMA goes by, especially on the street. You can see most of them listed there. I would say ecstasy and Molly tend to be the two that were identified most commonly. It is a synthetic stimulant and hallucinogenic medication. I guess substance is probably a better term there, but it is synthetic. It was something that was created. So Merck actually created it in 1912. They created it specifically because a competing drug company, Bayer, had a different drug, hydrastinine, that they were using as a hemostatic agent. It was the only agent that was available at that time, and they were looking for different metabolites, things that were structurally close to that, to try to essentially steal some of the market share from Bayer. They didn't do it, they got it patented in 1912, but there wasn't as much of a demand as they had been hoping for. So they didn't do much to evaluate the biologic activity and pursue official FDA approval for years. So it wasn't until the 1950s that Merck was approached by the US military. Actually, they were looking for different substances they could use as a truth drug for individuals that were being questioned. So MDMA initially started going under clinical investigation to see if it could be used as a truth drug. Because of some of the effects that they started to see with MDMA, which we'll talk about in just a minute, it was absorbed, adopted into the psychotherapy realm. So in the 1970s, there were several places that were actively using MDMA as part of their psychotherapy sessions. All of this being somewhat off-label, it was reevaluated, and in the mid-1980s, about 1985, it was listed as a Schedule I substance. So there were some concerns about its use, the potential for it to be misused, so it was moved to a Schedule I. In the late 20-teens, so 2016, 2017, there was some authorization granted, and there started to be renewed interest in looking at MDMA. So similar to other illicit agents, things like cannabis and psilocybin, they're looking again at MDMA for potential places that it could be used. So it's had kind of an interesting history. That's its official history. Now, on the unofficial side of things, as the MDMA became more robustly available, it became more illicitly available. It peaked, it initially had peaked in the 1990s. It was primarily used in some other locations, which has changed a little bit, but it can be found in a whole bunch of different forms. So because its use was relatively off the radar for a while, there was a lot of creativity in the different dosage forms that have been created. So it's available as crystals, as gel capsules, as liquid, as powder, as tablets. For the most part, it tends to be taken orally. Most of the time, most of the products that have been confiscated are in the forms of tablets or powders. They tend to be very colorful. There are all kinds of different designs that are stamped on the tablets, different I almost said manufacturers, different creators of the tablets have their own symbol that go on them. Some of them are a Nike swoosh, what looks like a Nike swoosh. There are different bugs, butterflies, birds, animals. There may be words that are on there. There are thumbs up. There's a little Rastafarian guy for some of them. There are several different forms that could take. As I had mentioned, it's usually taken orally, but it can be smoked, snorted, or injected, but that doesn't tend to be the main way that the MDMA is used. So it's got quite a history. How often are we seeing it being used? So the 2022 data from the National Survey on Drug Use and Health, they ask individuals who are 12 years or older if at any point in their lifetime they have used ecstasy. And that was about 0.5%. So not one of the most frequent agents. But when we look at past year use, so have you used this within the past year? It was over 2 million individuals. And then in the past month's use, it's over 389,000 individuals. There's some discussion on whether or not the use is going up versus not. Depending on the data that you look at, in some cohorts, it might be. It looks like the numbers have dipped slightly between 2021 and 2022 in past year and past month use for the younger cohort. But those who are adults and older, it looks like it's stayed the same or gone up just slightly in those same past year and past month use. So not a robust change, but it definitely is out there. As I had mentioned, it really peaked initially in the late 1990s, and it was primarily seen in different rave and club scenes. So overnight parties, different music festivals, these tended occasionally to be partnered with the use of ecstasy in terms of what the stimuli look like in these particular places. There tended to be a lot of tactile stimulation. There could be a lot of lights. There may be a whole bunch of other things that were available to individuals who are going to be using ecstasy in those scenes. Interestingly, more recently, the expansion has come to different areas. So beyond just this more rave and clubs party scene, but to smaller parties, to just regular use. So they are seeing it diversify quite a bit. The most common individuals who do report use of ecstasy are those who are 26 years and older. So as I had mentioned, kind of the younger patients, we didn't see it being used quite as prominently. The younger adults, so 18 to 25, it looked more like it was holding steady, but there was a slight increase for those 26 and older. So why might they use this? What exactly is it that it's doing? So it's believed, and much of this is based somewhat on human trials, but quite a bit of the initial information has come from animal trials, is that there's an increase in neurotransmitter release. So for dopamine, norepinephrine, and serotonin, it appears to be able to interfere with the synaptic vesicles. So within your neurons, the cells in your brain, you have these little, they're almost like bubbles that contain your neurotransmitters. So the neurotransmitters are what help all of the cells in your brain communicate with each other. They're supposed to be in there. They're protected from all of the other things that are going on inside your brain cells. Well, ecstasy seems to, the MDMA seems to interfere with those bubbles. It reduces the integrity and allows them to be released. Once they're in the neuron, they can diffuse right across. And now there's more of the neurotransmitter that's available to act on the other brain cells and neurons, to send messages, to really start to change some of the signaling from what it had been previously. Other actions that they see is that it does have an impact on the transporters, where they're unable to essentially pull the dopamine, norepinephrine, and serotonin back into the neurons. So it does stay out in that area and able to act for a slightly longer period of time. Now, that may seem like it's increasing all of the neurotransmitter signaling. That's true partially, but some of its other actions are it can inhibit some of the enzyme activity. So in some individuals, they actually see drops in some of the neurotransmitter levels. Because dopamine, norepinephrine, and serotonin are involved in so many different things, they've looked at other mediators. So what else are we seeing kind of down the line? And they found changes in cortisol levels, prolactin, oxytocin, vasopressin, a whole bunch of different agents. So that DHEA, they actually think that may be involved in the euphoria. So the changes in the DHEA concentrations seem to correlate with the small number of trials that they've done, how people are reporting their symptoms. So the higher the DHEA, the more euphoria that they've seen. The higher the oxytocin, the more socially engaged some of the individuals tend to be. In terms of long-term, so that's what happens when an individual takes MDMA, but more long-term use, they found some changes in enzyme activity that can be sustained. So it does appear to interfere with the enzymes that create these neurotransmitters, which ultimately over time may diminish their concentration. It also seems to alter the neurotransmitter transporter density. So if it's attaching to the transmitter, it doesn't work the same way as our antidepressants, but when it attaches to the transporters, it looks like the brain is actually pulling them back in, saying, okay, you're out of commission, you're not working the way you're supposed to, we're gonna reduce the number of them that we have out there. And that also can change some of the brain signaling. And because the dopamine, norepinephrine, and serotonin are out there and available, they often can be attacked by other things that are both in the neurons themselves or in the synaptic space between neurons. They can oxidize relatively quickly, especially if they can't be transported back into the neurons. And by oxidating, they can cause all kinds of additional issues. So long-term effects with that increased oxidation, they've seen changes in a number of other factors. So increased in pro-inflammatory cytokines within the brain that may have an impact on some of the enzyme activity, as well as a number of other signaling processes that aren't working quite as efficiently as they had been prior to MDMA use. So it's still under investigation, but there do look like there's pretty significant effects that happen with the use of MDMA, especially on the long-term side of things. So what might all of that do? So that was a ton of information. So what do we see? We can't see that the dopamine, norepinephrine, and serotonin are much more prominent. It seems like the serotonin signaling is the main one that we see with the use of MDMA. There are changes, blood pressure and heart rate tend to increase. Temperature dysregulation tends to be a big issue, both short-term and long-term, and potential consequences of being able to regulate body temperature. It can decrease inhibitions. There tends to be a distorted sense of time, as well as sensory perception, especially tactile sensory perceptions. So individuals, that's why I had mentioned at some of the raves, they may have different stimuli that were there. So they talked about some of the touch curtains that they would have that had different textures on them, or the fact that they would have scented bubbles or foam that would come out during some of the parties, because it was much more, individuals were much more engaged with that, especially if they were actively using MDMA. Tended to cause increased euphoria. That's really what a lot of the individuals are hoping for. Heightened awareness or alertness. Some individuals may feel faint. That may be related to the increase in blood pressure and heart rate. There is an increase in muscle tension overall. Some individuals will feel it in other places, but it's most often reported with like jaw clenching, so especially in the face. So several places where there is extensive MDMA use, would give out the individuals binkies or pacifiers for individuals to chew on, so that they weren't actually grinding their teeth or clenching their jaw to the point that it actually caused them issues later on in the morning. And then nausea was the last one. In terms of long-term, so that could happen right when an individual is taking this, but if they're taking the MDMA on a more chronic basis, we saw that there is the potential for additional changes. Some of the effects that they've seen with more chronic use are an increased risk of anxiety, increased prevalence of anxiety symptoms, impairment in attention and learning, confusion, memory difficulty, oftentimes short-term memory difficulty, increase in depressive symptoms, impulsiveness, as well as sleep difficulty. And that was reported going in both directions. More commonly, insomnia, but there were some issues with individuals being overly fatigued. So seeing that it can impact a number of different factors, we are systematically looking at where might this be able to be used. So the places it's been investigated are listed here. So post-traumatic stress disorder, this seems to be I don't want to say highest priority, but the greatest focus for the use of MDMA right now. Anxiety and mood disorders, not much of a surprise. In the 70s, they were trying to facilitate psychotherapy, and that really could play a role with both anxiety and mood disorders. Not as much with psychotic disorders. They haven't seen quite as much or had quite as much success in looking at it in that population. They are looking at it for autism spectrum disorder, specifically trying to target some of the social impairment, and then in pain for patients with terminal cancer. So more of experimental studies in that particular patient population, and that one's relatively small. I'm not going to spend as much time on that one. We're going to look at one of the bigger trials for PTSD. Then we'll talk a little bit about the anxiety, depression, as well as autism spectrum disorder briefly. So for PTSD, this was one of the more robust trials, even though it only had 91 patients. So randomized, double-blind, placebo-controlled. Now, the way almost all of these are set up, there are 3 prep sessions. So psychotherapy sessions with the individual, then the individual takes the medication. So they're either given the MDMA or they're given a placebo. They're supervised. It usually takes place over the better part of a day, 6 to 8 hours, if not longer. And then after the medication session, there are 3 integrative sessions to really talk through what the experience was, help the patient with processing. And then that whole sequence is repeated. 3 prep sessions, medication or placebo is administered, and then 3 of those integrated sessions afterward. For the PTSD patients, their primary outcome was changes in the clinician-administered PTSD scale. And what they found, these are the results from the trial. The patients, the blue line, which is on top in all 3 of these graphics, are the placebo patients. The red line, or the bottom line, are the patients who were given MDMA. I'm just going to focus on the top one just for sake of time. So they saw a pretty significant decrease in PTSD symptoms in patients who were on MDMA. The difference was seen after the second session and was maintained by the time they were at the end, or at the 18 weeks of the study. So after the first session, there was a little bit of a difference between the 2, but it wasn't statistically significant. They did see a more prominent difference after the second session. When they looked specifically at patients who were treated with placebo versus those that were treated with MDMA, the results were pretty impressive. So these folks did have pretty significant response. I want to focus on the dark colors here at the bottom. This darkest red are the number of patients who were in remission. So essentially their symptoms were mild to no symptoms whatsoever. There was just under 10% after the first session, just over 10% after the second session, and then about a third of patients were in remission by the end of the third session. And just compare that to placebo, they were less than 5% by the end of the third session. So they really saw a significant response in those patients. If you look at just the pink bars in general, those are patients who were considered responders, and it was almost 80%. Just of note, these patients had had PTSD for over 14 years. They were in their late 30s to early 40s and had pretty markedly severe disease at baseline. So the fact that we had responders, so significant reduction in symptoms in 80%, and a third of them were able to achieve remission does suggest that there is a benefit there. In terms of adverse effects, there was some muscle tightness, loss of appetite, nausea, hyperhidrosis, so excessive sweating, some temperature instability with fever and chills, and then transient increases in blood pressure and heart rate. But that did not result in discontinuation of treatment for those patients in the MDMA group, so it didn't make them drop out. So likely you are going to be seeing more about MDMA for PTSD. That's the highlight. The rest of these, not quite so much. Looking at anxiety, this was probably the strongest trial I could find. It was specifically looking at social anxiety, randomized, placebo-controlled, double-blind. This was just in adults with autism. I promise we'll look at this autism spectrum disorder again, but these were patients who were same setup, 3 prep sessions, a medication session, 3 integrative sessions, and then they did the whole cycle again. So their medication sessions were spaced about a month apart. This time, though, for these patients, the dose they were given first for the first session was lower than the dose they were given the second time. So in the first group, the first cohort of patients who went through, they were given 75 milligrams and then 100 milligrams of MDMA. In the second cohort that came through, they were given 100 milligrams, then 125 milligrams. So they were really trying to establish what would be the most appropriate dose. Their outcome was changes in the Leibowitz Social Anxiety Scale. MDMA this time is going to be the blue group. Placebo is the red bars. At baseline, there was no difference between the two groups. They both were relatively severe, had severe social anxiety. Anything over 80 falls into that category. After the 1 month after they received both doses, they saw a significant reduction, so more than a 50% reduction in the MDMA group. So a statistically significantly greater drop in those social anxiety symptoms, even after they had taken that MDMA. They then followed up with patients 6 months later, and interestingly, that improvement in symptoms was maintained, not only for the MDMA group, but also for the placebo group. So likely they are going to continue to explore that, maybe not quite as robust as what we saw with PTSD, but a suspicion that there may be some efficacy there for anxiety. All right, for our autism spectrum disorder, this one was a little trickier to find. This was a systematic review that included studies in patients with autism spectrum disorder that used MDMA or placebo. Those studies used all kinds of different doses. Most commonly, it was 1.5 milligrams per kilogram or a total of 100 milligrams. They were looking at changes specifically in social behavior, so pro-social behavior. They did have to administer the testing, so they gave them the dose, and then there were some evaluations that were done. There was a lot of variability. So some of them evaluated patients 30 minutes after they took the MDMA. Some of them did it much, much later, 2 hours, 3 hours, 6 hours, 8 hours later. Most of them used their own internal reporting. So the results aren't quite as clear-cut as the rating scales we just looked at, but they did see increases in all of the categories that are listed here. So self-perception of extroversion, so they felt like they were more extroverted. changes in friendliness, insightfulness of others, openness to be in social environments, sensitivity, and that was kind of described as caring or kind of doing outreach in emotional demonstrations with those that they were around, talkativeness and thoughtfulness. They also did not have many adverse effects. Increased muscle tone, difficulty concentrating, fatigue, and decreased appetite were the primary adverse effects in that group. So possibly they may continue to look at that in this patient population. It was a little while ago, so I'm not quite sure that that's going to be something that's going to make as many waves as what we see with PTSD. The last one that I'm going to talk about here just briefly is MDMA for depression. There really isn't much out there currently. However, there is a clinical trial that is underway. It's a proof of concept trial that's being done in Norway. So they're recruiting adult patients with major depressive disorder, and they're looking at change in their major depressive disorder symptoms at 8 weeks. So they are going to follow that same 3 steps, 3 prep sessions, a dose, 3 integrative sessions, and then follow it again. The second dose, again, is going to be separated by a month. So they want to make sure they're not giving them MDMA right in days back to back, but they are separating it out for a month. So it is currently underway. There's no initial reports that I could find on the results yet, but that will be something that should be coming before too long. Because there often are consequences and adverse effects, these are the ones that are most commonly reported. They were consistent with what was seen in most of the clinical trials. Interestingly, all of the clinical trials have been short-term. So in terms of what does this mean long-term, especially with things like that concentration difficulty, is something that's going to need to be evaluated. Plus, how many sessions are necessary? If we're setting this up and dosing it once a month, is it once a month for a certain number of sessions? What are those regimens going to look like? All of that is still under development. So to wrap up, MDMA works generally by altering our neurotransmitters, our monoamine neurotransmitters, but it also seems to impact some of the hormonal signaling. So there is increased interest in where we could incorporate this. I would say PTSD looks like it has the most traction at this point. It has the strongest data, and it definitely is gaining quite a bit of attention. From a tolerability perspective, at least short term, it seems that it's relatively safe, and it is tolerable for the patients who have undergone the clinical trials. But long-term, we still need to evaluate what that's going to look like, because there are some potentially concerning things, including some of the cardiovascular findings. So with that, I will stop my share and turn things back over.